My name is Jessica Dunbar. I'm a pharmacy student at Duval College. My journal club topic is diazepam memantine for moderate to severe Alzheimer's disease. The reason I picked this article is because my grandmother currently has moderate Alzheimer's disease and is taking diazepam, or Aricept. I wanted to learn more about not only the drug choices for Alzheimer's disease, particularly diazepam, but also the disease state to be able to talk with my whole family about my grandmother's current disease state. The source is the New England Journal of Medicine. The primary objective: to compare patients with moderate to severe Alzheimer's disease who are already receiving the drug diazepam and test whether they will benefit from staying on diazepam alone, discontinue diazepam altogether, or add a new drug, memantine, for synergistic effects to their current regimen to help enhance cognition and function. Primary efficacy measure. The co-primary outcomes were scored on the standardized mini mental state exam and the caregiver-related Bristol Activities of Daily Living scale. The standardized mini mental state exam is a brief 30-point questionnaire test that is used to screen for cognitive impairment. It includes questions that test for arithmetic, memory, and orientation. Score ranges from 0 to 30, with higher scores indicating better cognitive function. On the caregiver-related Bristol Activities of Daily Living scale, it is a 20-item questionnaire designed to measure ability to carry out daily activities, such as dressing, preparing food, and finances, on which score ranges from 0 to 60, with higher scores indicating greater impairment. The study design: a 52-week prospective, multi-centered, randomized, double-blinded, and placebo-controlled clinical trial. Subjects in this article include community residents taking diazepam who had moderate to severe Alzheimer's disease and had caregivers who either lived with them or visited daily. Inclusion criteria for the study would involve participants who met standardized clinical criteria for probably or possible moderate to severe Alzheimer's disease by having a score between 5 to 13 on the SMMSE and have been prescribed diazepam continuously for at least 3 months at a dose of 10 milligrams for at least the previous 6 weeks. This study is also looking for the patient's prescribing clinician to be the judge and consider a change in drug treatment. The caregivers for the patient must either live or visit daily and agree in writing along with the patient for their own involvement in the study. Exclusion criteria. Patients not eligible for the study would be those that had severe or unstable medical conditions, were receiving memantine, or were considered unlikely to adhere to the study regimen. Study period. Total of 295 participants were enrolled in February 2008, and the last participant completed the study in March 2010. The outcomes were assessed for 52 weeks. Monitoring. Participants were randomly assigned to one of 4 treatment groups. 1 being continuation of diazepam with placebo memantine. 2 being continuation of diazepam and initiation of treatment with memantine. 3 discontinuation placebo of diazepam and initiation of memantine, and the 4th being discontinuation or placebo of diazepam and placebo of memantine. Efficacy and safety data were reviewed by an independent data monitoring and ethics committee every 6 months during the course of this trial. Data analysis. Primary analysis of the primary outcome measure was done using the intended-treat method. Power was set but not met, with a minimum patient size needed of 340 participants. The study recorded only 295 patients randomized between the 4 study groups. Therefore, like I said, the power was set but not met. Data analyzed was the estimate additional benefits of combination therapy between diazepam with memantine. Also, estimate the difference between the active drug diazepam or memantine and placebo. Both of these data were used statistical tests of the multi-level modeling repeated measure regression tests. The multi-level modeling for repeated measures data is a modeling change over time. It is a growth curve modeling technique which allows for estimation of individual differences in patterns of responses over time, or growth curves. I believe it is appropriate to measure this data analyzed because it is measuring the benefit or reaction of each drug with the improvement of participant in cognition and function. Results. I have attached 2 graphs. For my first graph, it is a line graph. It's a graph of scores of standardized mini mental state exam located on the left and the Bristol Activity of Daily Living scale located on the right. And it shows the range that the participants scored with their study drug, respectively. The higher the score on the SMMSE indicate better cognitive function, and the higher the score for the BADLS indicate greater impairment. Therefore, you could tell that the active diazepam and active memantine for both graphs show the greatest cognitive function and very limited impairment. Although as the study progressed, you could tell through both the BADLS and the SMMSE scores that the participants got progressively worse. For my second graph, in my results section, according to this graph above, in the number of people who continued versus discontinued diazepam for both standardized mini mental state exam of a p less than 0.002 and Bristol Activities of Daily Living scale of a p less than 0.004 with each visit. Therefore, there is a statistically significant difference. For both diazepam and memantine, the benefits with respect to scores on the SMMSE and the BADLS appeared to be larger in the absence of the other agent than in the presence of the other agent, although these differences were not significant, with a p-value of 0.14 and a p-value of 0.09 respectively. Tolerability. 6 out of a total of 188 serious adverse events that were reported were considered to be possibly related to the study drugs. None of those were considered to be unexpected serious adverse reactions. Patients who discontinued diazepam did not have abrupt withdrawal phenomena, although withdrawal was more significant with patients who were taken off the study drug and being put on the placebo form, with the majority of withdrawals occurring between weeks 6 and 18, that is located in the results section. There was no statistical significance that the incidence of serious adverse events or death differed according to treatment group, with a p-value of 0.77. Author's conclusions. Participants in the study were identified to have significant benefits in both cognitive and functional outcomes of continued diazepam therapy, p-value less than 0.01. Although the benefits of initiating memantine was less significant than continued diazepam alone, it still showed some importance with a p-value less than 0.05. Finally, no significant effects occurred with both memantine and diazepam together when trying to show a synergistic effect to better therapy. Strengths. Biostatistical tests appropriate for data type. Outcome measures valid with SMMSE and Bristol Activities Daily Living Scale. Inclusion criteria adequate along with exclusion criteria adequate. Randomization resulted in 4 treatment groups. Length of study of 52 weeks was appropriate to show effect. Treatment regimen and doses appropriate. All drugs were within safe and therapeutic ranges. Blinding was significant to mass data. The study was double-blinded. Author's conclusions supported by results. Limitations of this study included power. It was set but not met, with an intend-to-treat analysis and a minimum sample size of 430 patients were needed, and this study only enrolled 295 patients. Level of evidence was a level 2 with major limitations. Recommendation. I do recommend diazepam for moderate to severe Alzheimer's disease for the following reasons. Efficacy. This level 2 trial with major limitations of power demonstrated that diazepam alone and in combination with memantine showed a statistically significant improvement, although the synergistic effects between the two drugs showed no statistical significance. There was no statistical benefit of adding memantine to diazepam with respect to scores on the SMMSE, a p-value of equal to 0.07, or with respect to scores on the BADLS, p-value of 0.57. Both diazepam and memantine are FDA approved for treatment of mild, moderate, and severe dementia of Alzheimer's type. Although it will not cure the disease, the drugs may help to reduce symptoms. The benefits of adding memantine to diazepam is not clear, and further studies are needed before a clear recommendation can be made according to the European Federation of the Neurological Society's guideline for Alzheimer's disease in 2010. Safety. Diazepam may have vagotonic effects which may cause bradycardia and or heart block with or without a cardiac history of disease. It may also include increased gastric acid secretion, so therefore use with caution in patients with risk of ulcer disease. Diazepam may cause dose-related diarrhea, nausea, vomiting, anorexia, or weight loss. Memantine can cause worsening of corneal conditions. Periodic eye exams are recommended. Cost. Diazepam or Aricept does have a generic available, and cost is 30 10 milligram tablets of $179. Memantine or Namenda does not have a generic available. Although cost is less significant than diazepam, 30 10 milligram tablets is $120. Both doses are taken once daily. As per the study, all patients had to take 2 pills daily, one of Namenda and one of Aricept. It was blinded with either active drug or placebo and were monitored by their caregivers daily. Special considerations or populations. Diazepam is a pregnancy category risk factor C. Although no adequate and well-controlled studies in pregnant women, memantine is a pregnancy risk factor B, although no studies in pregnant women. Dose adjustment is necessary for memantine with severe renal impairment. This concludes my journal club presentation. Thank you for your time. Feel free to email me if you have any questions. Thank you.